imagine for a moment that you are walking a tightrope. But this isn't just any tightrope suspended in a circus tent with a safety net below.
Okay.
This rope is microscopic, razor thin, and it is suspended over a canyon that represents total physiological collapse. Now, to make matters worse, imagine that tightrope isn't just reacting to your weight. It's reacting to the wind, the temperature, the humidity, and even that turkey sandwich you ate for lunch. To stay on that rope, you have to make thousands of micro adjustments every single second. If you lean too far left, you fall. Too far right, you fall.
That is a genuinely terrifying image to start a deep dive with.
It is, isn't it? But that is exactly what is happening inside your blood vessels right now at this very second. We are talking about the high-stakes chemical laboratory of the human body, where a difference of just a few decimal points—
And you mean that literally?
Literally, we are talking hundredths of a point— is the difference between feeling great, falling into a coma, or facing absolute catastrophe.
It sounds dramatic, but chemically speaking, we are all walking that tightrope every moment of our lives. It's the definition of a high-stakes environment. And most of us have no idea it's even happening.
Not until something goes wrong.
Exactly. Not until you fall.
Today, we are decoding the body's chemical balancing act. We are diving into a topic that usually makes medical students sweat through their scrubs and seasoned clinicians pause to double-check their math: acid-base disorders.
It does have a reputation for being dense, doesn't it? It's heavy on math, heavy on chemistry, and it involves a lot of, memorization. But at its heart, if you strip away the formulas, this is really the story of homeostasis.
Right.
It's the story of how your body fights against constant threats, both internal and external, to keep your internal environment stable enough for life to exist.
Precisely. And to guide us through this, we're looking at a source that pulls no punches. We're deep diving into Chapter 72, simply titled Acid-Base Disorders, from a comprehensive medical text on renal disorders and pharmacotherapy.
This text is excellent because it doesn't just give you the what. It breaks down the math, the biology, and the treatments. It doesn't just say acidosis is bad. It explains exactly why it happens, the physics of it, and how the body tries to fix it using some pretty ingenious mechanisms.
Our mission today is to decode what they call blood gas secrets. I know for a lot of people, and honestly for me too, you see a phrase like logarithmic scale or serum anion gap, and your brain just wants to shut down.
Who wants to go watch cat videos?
Exactly. But we're going to bypass the panic.
We're going to translate the jargon.
Right. We want to move beyond just memorizing a number like pH 7.4 and understand how the body fights to stay there. Because when you read this chapter, you realize it's a war in there.
It is. And while the math can look intimidating, the core concept is actually beautifully simple. It comes down to a balance between two things: acids, which are basically hydrogen ions, and bases, primarily bicarbonate.
Okay, acid versus base.
And there are two main organs that control that balance: your lungs and your kidneys.
Lungs and kidneys. The tag team champions of the blood.
That's it. If you can keep those two players in mind, lungs and kidneys, acid and base, you can understand almost anything that goes wrong with the body's pH. It really creates a framework for understanding human survival.
So let's unpack this. Let's start with the landscape. We need to define the safe zone. The source material throws out a very specific number, 7.40.
Right. The normal arterial pH is 7.40, but biology is rarely perfect, so there's a tiny range of acceptability. We consider normal to be anywhere between 7.35 and 7.45.
That is incredibly narrow. When you think about the pH scale generally, running from 0 to 14, having a safe window of just 0.1 seems like, I don't know, a design flaw.
Or living dangerously.
Or at least living dangerously. I mean, orange juice is pH 3, bleach is pH 12. We are balancing on the head of a pin.
Or it's a design masterpiece, depending on how you look at it. Because proteins, enzymes, all the little machines that make your cells work, they are incredibly picky. They are folded into very specific 3D shapes. And that folding depends on the electrical environment, the acidity around them.
The tertiary structure of proteins depends on the hydrogen ion concentration. I remember that from biology class.
Exactly. If the pH changes, the electrical charges change, and the protein unravels. It denatures. If the pH drops below 7.35, we call that acidemia.
Okay, academia.
If it goes above 7.45, it's alkalemia. And if you stray too far from those numbers, say below 6.9 or above 7.6, cellular machinery just stops working. Enzymes denature. Metabolic pathways shut down. The heart loses its ability to contract because the calcium channels fail.
It's just incompatible with life.
It is incompatible with life, full stop.
So because the window's so tight, we need a defense system. The source talks about buffering. Now, when I hear buffering, I think of a streaming video loading. But here, we're talking about chemistry.
We are. In chemistry, a buffer is a solution that resists changes in pH when you add an acid or a base to it. Think of it like a sponge on your kitchen table.
Okay.
If you spill some water, which represents acid in this analogy, the sponge soaks it up so the table doesn't get wet.
I like that visual. It hides the acid.
Temporarily, it doesn't eliminate it, it just sequesters it so it can't change the overall acidity of the solution. The MVP of buffers in the human body is the carbonic acid bicarbonate system.
H2CO3 and HCO3.
That's the one. It looks like a complex chemical formula, but it's essentially the body's shock absorbers.
Shock absorbers is a great way to put it.
Yes. Imagine driving a car over a pothole. The shock absorber compresses to take the hit so the car doesn't bounce off the road. When your cells produce acid, and they produce a huge amount of acid just by existing and metabolizing food, this bicarbonate buffer system takes the hit.
Instantly.
Instantly. It binds to the hydrogen ions immediately so the pH of your blood doesn't swing wildly.
And this brings us to the fundamental equation that rules this entire deep dive. The Henderson-Hasselbalch equation. We won't make the listener do the math.
Please don't.
But conceptually, what is this telling us?
Conceptually, it tells us that the pH of the blood is determined by the ratio of bicarbonate to carbon dioxide. It's roughly a 20.1 ratio.
20 to 1.
As long as you keep 20 parts bicarbonate for every 1 part carbonic acid, which comes from CO2, your pH stays at 7.4.
So it's all about the ratio. It's not about the absolute amount, but the relationship between the two.
Exactly. You can have high levels of both or low levels of both, but as long as that 20.1 ratio is preserved, the pH is normal. It's a teeter-totter. The balance is everything.
So let's introduce the players in this system properly. We have the shock absorbers, but we also have the things causing the bumps. The source breaks it down into a respiratory component and a metabolic component.
Correct. On one side, you have carbon dioxide, CO2. This is the respiratory component.
Now, CO2 is a gas, but in the blood, it acts like an acid. I don't know if that worked.
Right. When CO2 dissolves in your blood, it combines with water to form carbonic acid. So for the purpose of our balance sheet, think of CO2 as an acid. Your body produces huge amounts of it just by breaking down carbohydrates, proteins, and fats. It is the exhaust fume of metabolism.
Okay, so CO2 equals acid. That's the respiratory side because we breathe it out. If we stop breathing, the exhaust builds up.
Right. And on the other side, the metabolic side, we have bicarbonate, or HCO3. This is a base. It's produced, reclaimed, and regulated by the kidneys.
So CO2 is the volatile acid managed by the lungs. Bicarbonate is the base managed by the kidneys.
You've got it. And that sets up the 4 quadrants of disorder that doctors look for.
The 4 quadrants. This sounds like a strategic grid.
It's simpler than it sounds. Since we have 2 variables, bicarb and CO2, and they can either go up or down, we have 4 possibilities. 1, metabolic acidosis. That's when you have low bicarb, you've lost your base.
Or gain too much acid that ate up the base.
Correct. We'll get into that distinction. 2, metabolic alkalosis, high bicarb. You have too much base.
So those are the 2 metabolic ones, kidneys.
Exactly.
Yeah.
3, respiratory acidosis, high CO2. You're holding on to too much acid.
The lungs aren't venting the exhaust.
And 4, respiratory alkalosis, low CO2. You've blown off too much acid.
Okay, I can visualize that. It's a 2x2 grid.
Yeah.
But how do doctors actually figure out which one is happening? You can't just look at a patient and see their pH level floating above their head like a video game health bar.
We wish. No, this brings us to the detective work. The primary tool mentioned in the text is the ABG, the arterial blood gas.
I've heard of this. It's not a regular blood draw, right? It's
Yeah.
a bit more intense.
It is. Usually when you get blood drawn for cholesterol or sugar, it's from a vein. It's
Yeah.
dark red, low pressure, deoxygenated blood returning to the heart. And ABG comes from an artery, usually the radial artery in the wrist.
Right to the wrist.
It's bright red, high pressure, oxygenated blood coming straight from the heart and lungs.
And honestly, it hurts a bit more.
It does. Veins have fewer pain receptors and lower pressure. Arteries are deeper and have nerve endings around them. But it gives us the gold standard data. The pH, the PaCO2, the measure of carbon dioxide pressure, and the bicarbonate.
So you get this slip of paper with these numbers. The source outlines a specific set of steps to diagnose what's wrong. Table 72 in the text.
Right. Step 1 is always look at the pH. Is it acid or base? If it's below 7.40, the primary problem is likely acidosis. If it's above, it's alkalosis. That points you in the right direction immediately.
Okay, so you know which way the tightrope is leaning. Step 2.
Check the culprits. Look at the CO2 and the bicarb. Which one explains the pH shift? For example, if your pH is low, so it's acidic, and your CO2 is high, which is also acidic, well, there's your answer.
They match.
It matches. It's respiratory acidosis.
But what if the pH is low, so it's acidic, but the CO2 is also low? CO2 is an acid, so low CO2 should make you alkaline. That doesn't match the pH.
Exactly. That's a mismatch. So if the CO2 doesn't explain the pH, then look at the bicarb. In that case, you'd likely see the bicarb is low. Low base equals acidic, so that would be metabolic acidosis.
It matches up. But here's where it gets really interesting and confusing for the uninitiated. Step 3 is compensation.
Yes. This is crucial because the body doesn't just sit there and let the pH drift. It fights back. It tries to restore that 20.1 ratio.
The text mentions that if you have a metabolic problem, the lungs try to fix it. And if you have a respiratory problem, the kidneys try to fix it. A cross-system backup.
Exactly. It's brilliant. Let's say you have metabolic acidosis. Your blood is becoming acidic because of something happening in your gut or kidneys. Your brain, specifically the chemoreceptors in the medulla senses this drop in pH and sends a signal to your lungs. Hyperventilate.
Breathe faster.
Yes, breathe faster and deeper. Because if you do that, you blow off more CO2. Remember, CO2 is acid. So by dumping CO2, you reduce the total acid load and pull the pH back up toward normal.
The lungs are bailing out the kidney.
They're trying to, and it works the other way too. If your lungs are failing, say you have emphysema and you can't get rid of CO2, your kidneys will sense the acidity and start holding on to more bicarbonate to neutralize it.
So they'll hang on to the base.
They will synthesize new bicarbonate and reclaim every molecule they filter. It's an all-hands-on-deck situation.
But there's a catch, isn't there? The timing.
A huge catch. The lungs are fast. They can respond in minutes. If you run up a flight of stairs and build up lactic acid, your lungs adjust your breathing instantly. You don't have to think about it.
And the kidneys.
They are slow. They are methodical. They take hours to start shifting, and it can take 3 to 5 days for them to reach maximal compensation.
So lungs are the sprinters, kidneys are the marathon runners.
That's a perfect way to put it. And clinically, this tells us a lot. If I see a patient with high CO2, but their kidneys haven't raised the bicarb yet, I know this is an acute problem. It just happened.
A sudden event.
Yes. If the bicarb is already high, I know this has been going on for days or weeks. It's a chronic condition.
That's a powerful diagnostic clue. I really like the seesaw analogy I've seen used for this compensation. If one side goes down, the body tries to force the other side down to keep the plank level?
Yes. If bicarb drops, causing acidosis, the body forces CO2 to drop by breathing it out to keep the ratio stable. The absolute numbers might be weird, both are low, but the ratio, and therefore the pH, stays safe.
For a while. Louise.
For a while.
Okay, so we have the landscape, we have the map. Now I want to dig into the specific monsters that inhabit these quadrants. The source spends a significant amount of time on metabolic acidosis. This seems to be the big one.
It is the most complex one to diagnose because there are so many potential physiological failures that lead to it. Definition-wise, it's simple. Low pH and low bicarb. But why is the bicarb low? That's the question.
The text lists 3 main mechanisms. You added an acid, you lost a base, or your kidneys just stopped dumping acid.
Right. And to distinguish between these, we use a mathematical trick called the serum anion gap, or SAG.
I love that they call it a gap. It sounds like a mystery novel. The mystery of the anion gap.
It kind of is. The formula is sodium minus the sum of chloride and bicarbonate. Basically, you take the major positive ion, sodium, and subtract the major negative ions we measure.
And normally, that equation doesn't equal 0. There's a gap.
No, it doesn't. Electrically, the body is neutral. Positive equals negative. But we don't measure every negative ion in a standard blood test. We measure chloride and bicarb. But there are others, albumin, phosphates, sulfates, that we don't routinely count.
So the gap is just the measurement of those uncounted negative ions.
Precisely. Normally, that gap is about 9 millieql, give or take. That represents the normal amount of unmeasured stuff.
Okay, so why does this matter for a diagnosis?
Because if that gap gets bigger, if it goes from 9 to, say, 20 or 30, it means there is a new unmeasured acid taking up space in the blood. It's displacing the bicarbonate. We call this high anion gap metabolic acidosis, or HGMA for short.
HGMA. And this is where we get to the scary stuff, the category A causes in the text. These are usually emergencies.
Yes, these are life-threatening. One of the most common is lactic acidosis.
That's what happens when you sprint, right? The burn in your legs.
Yes, that's physiologic lactic acidosis.
Yeah.
But in a medical context, we see it systemically. It happens when your tissues aren't getting enough oxygen, like in severe shock, heart failure, or sepsis. The whole body switches to anaerobic metabolism.
So no oxygen.
It starts pumping out lactate.
So the runners burn, but all over your entire body.
Exactly. And the lactate is an acid. It eats up your bicarbonate, widening the gap. The text actually differentiates between type A and type B lactic acidosis.
What's the difference?
Type A is hypoxic. You aren't getting oxygen to the tissues. That's shock. Type B is metabolic. You have oxygen, but your cells can't use it properly or are overproducing lactate for other reasons.
Like what?
This can happen with liver failure, malignancies, or certain drugs like metformin or even some HIV medications.
Fascinating. So even with oxygen, the engine can be broken.
Correct. Another huge cause of high gap acidosis is diabetic ketoacidosis, or DKA. This is often how type 1 diabetes is discovered in young people.
What's the mechanism there?
The body has plenty of sugar in the blood, but because it lacks insulin, the cells can't access it. They are starving in the midst of plenty.
So they panic.
The body panics and switches to plan B, burning fat for fuel.
And burning fat produces waste.
The byproduct of rapid fat metabolism is ketones, specifically acetoacetate and beta-hydroxybutyrate. These are keto acids.
So you are acidifying your own blood by burning your own fat reserves too quickly.
Precisely. The patient will often have a fruity odor to their breath. That's acetone, a type of ketone. But inside, their chemistry is crashing. The gap widens significantly.
And then there are the toxins. The source mentions some truly nasty stuff. Methanol.
That's wood alcohol. People sometimes drink it as a cheap substitute for ethanol or accidentally in moonshine. It's incredibly dangerous.
The text says it causes blindness.
Yes. The liver breaks methanol down into formic acid. Formic acid is toxic to the optic nerve. It literally blinds you while it acidifies your blood.
And ethylene glycol, that's antifreeze.
Correct. It's sweet, so sometimes children or pets ingest it. It breaks down into glycolic acid and oxalic acid. The oxalic acid binds with calcium and forms crystals.
Kidney stones.
Yes, but right inside the kidney tubules. It causes acute catastrophic kidney failure.
These are terrifying. So if you see a massive gap, you have to think toxins.
Absolutely. The mnemonic used to be mud piles, now it's gold mark, but the concept is the same. Look for the hidden acid.
The list also mentions salicylate overdose. That's aspirin.
Yes, aspirin overdose. It's a classic board exam question because it causes a complex mixed disorder, which we'll get to, but it definitely drives up the anion gap due to salicylic acid and the metabolic disruption it causes.
Okay, so that's the high gap group. Something new, lactate, ketones, toxins has been added. But what about category B, the normal anion gap?
In these cases, the gap is normal, around 9, but the patient is still acidic. This implies that they aren't adding a new acid. Instead, they are losing bicarbonate directly.
Where does the bicarbonate go?
Usually out of the body. The most common cause is diarrhea.
Really, just diarrhea?
Yes. The fluids in your lower GI tract, your intestines and colon, are very rich in bicarbonate to neutralize stomach acid. If you have severe diarrhea, you are literally flushing your body's base down the toilet.
That's a vivid image.
Your bicarbonate levels drop, your pH drops. But here's the trick. To keep the electrical charge balanced, your kidneys hold on to chloride. So bicarb goes down, chloride goes up.
And the gap stays the same.
The gap, which is sodium minus chloride minus bicarb, stays the same because the chloride rose to replace the missing bicarb.
So high gap means you added acid. Normal gap means you lost base and replaced it with chloride.
We call it hyperchloremic metabolic acidosis.
The other cause listed for normal gap is something called RTA renal tubular acidosis.
This is when the kidney's plumbing is broken. The kidneys are supposed to reabsorb the bicarb that passes through them. In RTA, they forget how to do that, or they forget how to excrete the daily acid load. The pipes are just not working right.
It's fascinating how physical the symptoms are for this metabolic acidosis. The source mentions cuspal respirations.
It's a very distinct breathing pattern. Deep, rapid, gasping breaths. It's not subtle. It looks like air hunger.
And that's the compensation we talked about earlier.
Exactly. It's the lungs screaming, "Get this CO2 out of here." It's often the first sign of severe metabolic acidosis, especially in DKA.
The source also mentions something disturbing about bones. Rickets in children. Osteomalacia in adults.
This is one of the most profound things about acid-base balance. Your body cares so much about maintaining that pH of 7.4 that it will destroy your skeleton to do it.
Wait, how does destroying the skeleton help pH?
Bone contains a massive reservoir of calcium and carbonate buffers. If your blood is chronically acidic, like in someone with chronic kidney disease who can't clear acid, the body will dissolve the bone mineral to release those buffers into the bloodstream.
To neutralize the
To
acid.
neutralize the acid.
That is wild. It will literally liquefy your structure to keep the chemistry right.
It prioritizes the immediate chemical environment, the electrical stability of the blood over long-term structural integrity. It's a hierarchy of survival. Chemistry first, structure second.
So how do we treat this? My instinct says, if they are acidic, give them a base. Give them baking soda.
And that is alkali therapy. It is an option, but the text notes it's highly controversial, especially in lactic acidosis and cardiac arrest.
Why? If acid is the problem, why isn't base always the answer?
Because of the chemical reaction. When you mix bicarbonate with acid, what do you get? Think of a science fair volcano.
You get fizz. You get CO2 gas.
Exactly. If you pump a patient full of IV bicarb, you generate a massive amount of CO2 in their blood. Now, CO2 diffuses across cell membranes very easily, much faster than the bicarbonate can, so the CO2 rushes into the cells.
And CO2 is an acid inside the cell.
Right. So while you might make the blood pH look better on paper, you can actually make the intracellular acidosis worse. You poison the cells from the inside while fixing the number on the outside.
That is a dangerous paradox.
Yeah. It is. Plus, you can cause sodium overload, bloating, and fluid retention.
So what's the guideline?
Don't try to make it normal. Just make it safe. We target a pH of about 7.20. We just want to keep them out of the danger zone where the heart stops working while we treat the underlying cause.
Treat the DKA, treat the sepsis.
Give insulin for the diabetes or antibiotics for the sepsis. Always treat the cause.
The text mentions a drug called tromethamine as an alternative. THAM.
Yes, THAM. It's an interesting molecule. It's an amino alcohol that acts as a proton acceptor. Theoretically, it neutralizes acid without generating CO2.
Sounds like the magic bullet.
Theoretically, but the expert note in the text is pretty dry. No evidence exists that tromethamine is beneficial or more efficacious than sodium bicarbonate. It's expensive, hard to get, and clinical trials haven't shown it saves lives.
So we stick to the basics. Treat the cause.
Always treat the cause. The acidosis is a symptom, not the disease.
All right, let's flip the script. Segment 4. Metabolic alkalosis. Too much base.
High pH, high bicarb.
The text makes a really interesting distinction here between initiation and maintenance. It says you need two things to go wrong to have this disorder.
Yes, this is a key concept. It's actually very hard to stay alkaline. Your kidneys are really, really good at dumping excess bicarbonate.
So they just pee it out.
If you just ate a box of baking soda, your kidneys would pee it out in a few hours. You wouldn't stay alkalotic.
So to have chronic metabolic alkalosis, something has to be stopping the kidneys from doing their job.
Exactly. You need an initiating factor, something that generated the extra base or lost the acid, and a maintaining factor, usually kidney dysfunction or volume depletion, that prevents the correction.
What causes the initiation? How do we lose acid?
The classic one is vomiting.
Okay, straightforward.
Stomach acid is hydrochloric acid, HCl. It's extremely acidic, pH of like 1 or 2.
Yeah.
If you vomit excessively, or if a patient has a nasogastric tube sucking out stomach contents after surgery, you are removing pure acid from the body.
And that leaves the remaining blood alkaline.
Precisely.
The text also mentions diuretics.
This is called contraction alkalosis. When you take water pills, loop diuretics, or thiazides, you lose water and salt. The volume of blood shrinks, it contracts, but the amount of bicarbonate stays roughly the same.
So the concentration goes up.
The concentration of bicarbonate goes up.
And that's the maintenance factor too, the dehydration.
Yes. When you are dehydrated or volume depleted, your body activates the renin-angiotensin-aldosterone system, RAAS.
RAAS.
Aldosterone tells the kidney, save sodium, save water.
At any cost.
At any cost. And the cost is that to save sodium, the kidney has to dump potassium and hydrogen. So it dumps acid into the urine to save volume. This locks the alkalosis in place. The kidney won't fix the pH because it's too busy trying to fix the blood pressure.
This leads to the chloride connection.
Yeah.
Doctors divide alkalosis into salt-responsive and salt-resistant. What's that about?
This is the key to treatment. We check the chloride in the urine. If the urine chloride is low, less than 10 mmQL, it means the body is desperate for salt and volume. It's holding on to every molecule of chloride it can find.
This could be the vomiting or diuretic cases.
Exactly. And the treatment is beautiful in its simplicity. Saline.
Just salt water.
IV. Normal saline. It gives the kidney back the volume and the chloride it craves. Once the volume is restored, the RAAS system turns off, and the kidney says, okay, now I can dump this excess bicarbonate. and the alkalosis resolves.
That's the responsive type.
Yeah.
What about the resistant type?
That's when the urine chloride is high, over 20. This implies the patient isn't volume depleted. In fact, they might be volume overloaded. This is usually caused by hormonal disorders like Cushing's syndrome or hyperaldosteronism.
Too much aldosterone.
Exactly. The body is pumping out hormones that force the kidney to dump acid, regardless of volume status.
Giving saline there wouldn't help.
It would make it worse. It would raise their blood pressure even more. You have to block the hormones or treat the potassium depletion.
The treatment section for alkalosis has some pretty extreme options for severe cases. Acetazolamide makes sense. It helps kidneys dump bicarb.
Yeah.
But hydrochloric acid.
Yeah.
We can give a patient IV hydrochloric acid.
In extreme cases, if the pH is dangerously high, like over 7.6, and causing seizures or arrhythmias, and nothing else is working, yes, we can infuse a dilute mineral acid.
That feels like the nuclear option.
It is. It has to be given through a central line, a big catheter near the heart, because it would burn the small veins in your arm. Ammonium chloride is another option. The liver converts it into urea and HCl.
It really highlights how dangerous severe alkalosis is. We tend to fear acidosis more, but alkalosis kills too.
It does. It causes constriction of blood vessels in the brain. It causes calcium to bind to proteins, which leads to tetany and seizures. And it makes the heart incredibly irritable and prone to arrhythmias.
Moving on to the lungs. Segment 5, the respiratory side. We said earlier the lungs are the fast responders, but they can also be the problem. Let's start with respiratory alkalosis, breathing too fast.
Hyperventilation. This is anxiety, panic attacks, pain, fever, even early sepsis or pregnancy.
The mechanism is simple. You are blowing off CO2 faster than your body makes it.
Correct. CO2 drops, pH rises. Very straightforward.
The symptoms listed are lightheadedness, confusion, even seizures. Why does low CO2 cause confusion?
This is a really important physiological point. CO2 is a potent vasodilator in the brain. It keeps cerebral blood vessels open.
So it widens them.
Yes. If CO2 drops too low, the blood vessels in your brain constrict aggressively.
Wow. So hyperventilating literally chokes off blood flow to your brain.
That's why you feel lightheaded and tingly. You are effectively inducing brain ischemia just by breathing too fast.
Is the paper bag trick real? Or is that just TV drama?
It works, and the logic is sound. It's a rebreathing device. When you breathe into a paper bag, you are breathing back in the CO2 you just exhaled.
You're raising your own CO2 level.
It raises your inspired CO2, which raises your blood CO2, dilates those brain vessels, and fixes the alkalosis.
Simple. Low tech.
Very. Clinically, we rarely treat respiratory alkalosis with drugs. If it's pain, treat the pain. If it's anxiety, calm the patient. If they are on a ventilator and the rate is set too high, turn down the rate. Fix the cause.
Now the flip side. Respiratory acidosis. Breathing too slow.
Retaining CO2. This is the won't breathe versus can't breathe distinction.
Won't breathe sounds like an attitude problem.
It refers to the central drive, the brainstem. A heroin overdose or a benzodiazepine overdose suppresses the respiratory center. The lungs are perfectly healthy, but the brain isn't sending the signal to expand.
So the command center is down and can't breathe.
That's a mechanical or muscular issue. COPD, severe asthma, something blocking the airway, or muscle diseases like Guillain-Barré or ALS, where the diaphragm is too weak to pump the bellows.
The symptoms here are scary. CO2 narcosis.
Yes. High levels of CO2 act like an anesthetic on the brain. It causes confusion, stupor, and eventually coma. It can mimic a stroke. Patients get headaches due to vasodilation causing increased pressure in the skull, swelling of the optic nerve, papilledema, and tremors.
And the compensation here is the kidneys working overtime.
But remember, they are slow.
Yeah.
If you choke on a piece of steak, that's acute respiratory acidosis. Your kidneys can't help you in time. Your pH will plummet rapidly.
Yeah.
But if you have COPD, that's chronic respiratory acidosis. Your kidneys have been compensating for years. They hold on to massive amounts of bicarbonate to neutralize that chronic CO2 buildup.
There's a specific warning in the text about oxygen therapy for these COPD patients. It says caution.
This is a classic medical student trap known as the hypoxic drive phenomenon, though it's a bit more complex than that. In a healthy person, the drive to breathe comes from high CO2.
That's the trigger.
If your CO2 goes up even a little bit, your brain screams brave.
but in severe chronic COPD.
The body gets used to high CO2, the sensors get desensitized, they stop responding to the acid level.
So what drives them to breathe?
Low oxygen.
Yeah.
Interceptors switch to prioritizing oxygen levels. They only breathe because they are slightly hypoxic.
So if a well-meaning doctor sees a COPD patient with low oxygen, say 88%, and slaps a high-flow oxygen mask on them to get them to 100%.
They might stop breathing. You fix the hypoxia, you remove their only remaining drive to breathe. Their ventilation drops, and their CO2 levels skyrocket into narcosis.
That is incredibly counterintuitive. You give them oxygen, the thing they seem to need, and you could kill them.
It's a nuance, but a deadly one. You have to give oxygen carefully. Just enough to keep them saturated around 90–92%, but not enough to kill their drive.
And bicarb. Should we give bicarb for respiratory acidosis?
The expert says. Rarely necessary and potentially harmful. If you can't breathe, adding more CO2, which bicarb generation does, is the last thing you want to do.
Right.
The treatment is ventilation. Put a tube in, put them on a BiPAP machine. You need to mechanically help them blow off the gas.
Got it. Fix the pump, don't just add chemicals.
Exactly.
Okay, we've covered the four corners, but life is rarely that neat. Segment 6 covers mixed disorders, the perfect storm.
Real patients rarely read the textbook. They often have 2 or 3 things going on at once.
Let's look at scenario A, cardiac arrest.
The worst case scenario. The heart stops, so blood isn't moving. Because blood isn't moving, CO2 builds up in the tissues because it can't get to the lungs to be exhaled.
Respiratory acidosis.
And at the same time, because there's no oxygen getting to tissues, you get massive lactic acid production.
And metabolic acidosis.
So you have acid on top of acid. It's a profound combined acidosis. The pH can drop to levels incompatible with life very, very quickly.
Scenario B, the critical surgical patient. The text says this is the most common mixed disorder.
Imagine a patient who had a big abdominal surgery. They have an NG tube sucking out stomach acid. What does that cause?
Metabolic alkalosis.
Right. They've likely had massive blood transfusions. Blood preservatives contain citrate, which the liver turns into bicarbonate.
More metabolic alkalosis.
And the respiratory side, they are intubated on a ventilator. If the settings are too high, they are being hyperventilated.
Respiratory alkalosis. So this
Yeah.
patient is getting hit with alkalosis from the stomach, the blood bag, and the ventilator.
Yes. Their pH could be dangerously high, 7.6 or higher. This is dangerous because it makes it hard to wean them off the ventilator. Their drive to breathe is suppressed by the high pH.
Scenario C, the salicylate overdose. We mentioned aspirin earlier.
Aspirin is tricky because it has a biphasic effect. It directly stimulates the respiratory center in the brainstem, causing you to hyperventilate.
So first, respiratory alkalosis.
Yes. But it also uncouples oxidative phosphorylation in the cells, causing lactic acidosis and ketoacidosis.
So shortly after, you get metabolic acidosis.
You get both at the same time. One force pushing pH up, the breathing, and another pulling it down, the acid production.
If you just looked at the pH, it might look normal.
Exactly. The pH might be 7.4. But if you look at the ingredients, the CO2 is incredibly low and the bicarb is incredibly low. The patient is very sick, essentially burning up from the inside, even if the pH number looks deceptively calm.
That's terrifying. It shows why you can't just look at the pH number alone. You have to look at the ingredients.
Always look at the ingredients.
And finally, scenario D, COPD plus diuretics.
Very common. A guy with bad lungs, so he's got respiratory acidosis, high CO2, takes water pills for his heart failure, which gives him metabolic alkalosis, high bicarb.
The disorders cancel each other out.
In terms of pH, yes. His pH might be perfect, but his ABG will show a sky-high CO2 and a sky-high bicarb. He's living on the edge of the cliff.
No reserve.
He has no room to compensate. If he gets a pneumonia, worsening his lungs, or gets dehydrated, worsening the alkalosis, he falls off the tightrope instantly.
We're coming into the home stretch here, segment 7. Treatment and monitoring nuggets. I want to talk about the math of dosing bicarb. The host note here says it highlights how precise this medicine is.
It is. When we do decide to give bicarb, we don't guess. The formula for a bicarb loading dose is 0.5, which represents the volume of distribution of bicarb in the body times weight in kilogram,
Okay.
times the difference between your desired bicarb level and current bicarb level.
That is specific. You calculate the deficit in milliequivalents.
Yes, because remember, overshoot is dangerous. We aim to correct only half the deficit in the first 24 hours, usually. Slowly does it.
I was amused by the oral options in Table 72 to 4, baking soda.
Good old Arm & Hammer. It's actually a very effective treatment for chronic metabolic acidosis in kidney patients. It's cheap and effective.
Literally a kitchen staple. And soda mint.
It sounds like a candy, doesn't it? But it's just a sodium bicarbonate tablet. These are great for chronic, mild acidosis, like in someone with chronic kidney disease who just needs a little daily boost to keep their bones safe.
Shoal solution is another one listed. Sodium citrate.
It tastes terrible, apparently, but it's a liquid. The liver converts the citrate into bicarbonate. It's useful for patients who can't swallow huge pills.
And monitoring. The text reiterates, ABGs are the gold standard.
You have to keep checking. The situation changes hour by hour. And remember the goal. The goal isn't always normal. The goal is survivable. We treat the patient, not the number.
I think that's a great transition to our outro. We've toured the four corners of pH. We've seen the acidosis and the alkalosis, the metabolic gut-kidney axis, and the respiratory lung axis.
We have covered a lot of ground. It's a complex world.
And the big takeaway for me is resilience. The body is incredibly resilient. It buffers, it compensates, it shifts breathing in seconds, it shifts kidney function over days. It will even melt its own bones to keep that blood pH stable.
It really highlights the hierarchy of survival. Structural integrity, muscle mass, comfort, those are luxuries. Electrochemical balance, that is life itself.
Which leads us to our final provocative thought. Consider the complexity of something as simple as eating a burger or running for a bus. Every bite, every step challenges this system.
It does. We think of ourselves as solid biological entities, but really we are just a walking bag of chemical reactions held in a very, very delicate suspension.
And here's the question I want to leave the listener with, based on what you just said. If the body is willing to sacrifice so much like its own scalar density just to maintain this number, 7.4, what does that tell us about the fundamental nature of life? Are we biology, or are we just electricity and chemistry trying to keep a charge?
That is a deep thought. It suggests that the spark of life might just be a pH of 7.4.
Something to mull over next time you take a deep breath. Thanks for diving in with us.
Always a pleasure.
Catch you on the next deep dive.